I'd like to thank the organizers for inviting me to this very interesting conference. I hope that not having Dr. Berseth here will not be too much of a problem, but I'll try to do my best to cover her lectures. Next slide, please. Okay. This is a baby that sometimes we have to take care of. A very low birth weight, premature baby who is having respiratory distress, have low APGAR scores. The baby's on mechanical ventilation and is getting prophylactic endomethacin. This is a tremendous challenge in terms of nutritional support and in terms of trying to give enteral nutrition to these babies. We really have some major challenges because the gastrointestinal tract is still not fully developed in a baby like this, and because the gastrointestinal tract is not yet fully developed, we have some major problems in using it. Next slide, please. Now, this is a baby who has developed necrotizing enterocolitis, and this strikes fear in the heart of all neonatologists when we see a baby like this. And because of that, all it takes is taking care of a couple of babies like this who have been fed by the enteral route. We always then think again the next time we see a premature baby whether we are going to try to feed the baby using the enteral route. So this is certainly a major problem that we have, and what I'd like to do over the next 40 or so minutes is talk about development of the gastrointestinal tract and relate it to some nutritional biochemistry and give you some ideas of strategies we might be able to use in these babies. Next slide, please. So some of the areas that I would like to discuss is when, how, and what we should be feeding the low birth weight babies. And this all depends on the capability to tolerate enteral nutrition. And this depends on the developmental readiness of the gastrointestinal tract. Now, first of all, I'd like to talk about intestinal growth, swallowing, gastroesophageal sphincter function, gastric emptying, intestinal motility, and then digestion, absorption, and assimilation. Growth of the gastrointestinal tract. The gastrointestinal tract, the human fetal intestine elongates 1,000-fold from 5 to 40 weeks. The length doubles in the last 15 weeks of gestation. So from a 25-week to a 40-week gestation, we have a doubling of that, the length of the gastrointestinal tract. The mean length of the entire gastrointestinal tract, that's the small intestine and the colon at term, is around 275 centimeters. Now, in the gastrointestinal tract, we have cells, and there are several different kinds of cells that are involved in digestion and absorption, but the main intestinal cell that is involved in absorption is the intestinal epithelial cell, the IEP, the IC. And, but here you can see that these cells are really present very early in gestation. Already at 9 weeks gestation, they are present in the gastrointestinal tract. But their function in the premature baby is still not yet fully developed, and I'll talk about that a little bit later. Next slide, please. Now, in terms of the surface area of the gastrointestinal tract, here you can see we have villi, which line the intestinal tract, and on top of these villi, you have the epithelial cells, and the epithelial cells have microvilli. Now, with the villi and the microvilli, we have a huge surface area of the gastrointestinal tract. In the adult, the surface area of the gastrointestinal tract approximates that of a tennis court. So there's a huge amount of interaction the intestine can have with the luminal contents. And a lot of that growth occurs during this last trimester of pregnancy. Next. Now, in terms of physiological processes, during the last trimester of pregnancy, the fetus swallows huge quantities of amniotic fluid, around 450 milliliters of amniotic fluid per day. And in that amniotic fluid, there is protein and there are other nutrients, actually, that help the gastrointestinal tract develop. This is suddenly interrupted at the time of preterm birth if we do not use the gastrointestinal tract for feeding these very low birth weight babies. Now, in terms of mechanical difficulties that these babies have, there's suck-swallow incoordination. And these babies have suck-swallow incoordination usually until about 32 to 34 weeks gestation. And this necessitates tube feeding, so we have to feed them by a tube. The esophageal sphincter tone is lower in premature babies. It's 4 millimeters in the premature baby, and at term it's 18 millimeters. The gastric emptying is delayed. Motility is disorganized. And the gastroanal transit from mouth to the anus in extremely low birth weight infants is 2.5 days, whereas in the term it's 12 to 24 hours. Go ahead. Just click a couple. Okay. Gastroesophageal reflux is a physiologic event. Just turn on the, okay. A physiologic event which involves retrograde movement of gastric contents into the esophagus. Most premature babies have gastroesophageal reflux. That does not mean that this is something that is necessarily causing them problems. Only if they start having symptoms, then this is called gastroesophageal reflux disease, and that's when it becomes a problem. Next slide, please. Go ahead, next. Now, as far as gastroesophageal reflux disease is concerned, the major problems that we see with this is recurrent vomiting, poor weight gain or weight loss. Some studies have actually used tubes to look in the esophagus, and they have seen increased erosion of the esophagus in some premature babies. There are some minor findings. Apnea is considered to be related to gastroesophageal reflux, but I'll talk about that more in just a little bit. Feeding refusal, recurrent pneumonia, and this is usually seen in babies who have central nervous system problems. Next slide, please. There are some foods and drugs which reduce the lower esophageal sphincter tone and function. One of the drugs that we use very, very commonly in the neonatal intensive care unit is caffeine. Caffeine causes gastroesophageal reflux. Theophylline, certain narcotics, calcium channel blockers, beta-2 adrenergic agonists, anticholinergics, and fatty foods all increase gastroesophageal reflux. Next slide. Now, in terms of whether we can actually recognize gastroesophageal reflux in babies is something that is still up to question. By just looking at the babies, can we tell that babies can have gastroesophageal reflux? Let me just ask the audience. You can raise your hands. Can you tell by just looking at the baby that the baby is having gastroesophageal reflux? How many? Okay. There's some people who say that they can tell. Okay, good. Now, there's actually some people who have done a study on this. Okay, Snell and colleagues did a study on this, and they looked at had nurses looking at these babies, whether they had, and they recorded whether they had gastroesophageal reflux or not, and then they also had a tube down in the esophagus to measure acid production. Well, they had 20 episodes of gastroesophageal reflux recorded in these preterm infants, and the nurses that said that they could tell that these babies were having gastroesophageal reflux, there was 74% inter-observer agreement, okay, saying that these babies were having some problems that looked like gastroesophageal reflux. However, no behavioral pattern was temporally correlated with gastroesophageal reflux. So the nurses were saying that they could see this behavior that looked like reflux, but when they actually did the recordings, there was very little correlation to what the nurses were saying was reflux and what they actually measured as gastroesophageal reflux. Next slide, please. Now, we frequently correlate apnea in premature babies with gastroesophageal reflux. And one of the reasons for this is because there's strong physiologic evidence that stimulation of the laryngeal afferent nerves elicits central apnea and laryngeal adduction. However, several studies have looked at this now, and gastroesophageal reflux and apnea do not appear temporally related in preterm infants. Next slide, please. There are some pharmacologic agents that are being used for gastroesophageal reflux disease, antacids, H2 receptor antagonists, famotidine or ranitidine, proton pump inhibitors such as omeprazole, and prokinetic agents. Next slide, please. Now, do some of these medications actually reduce apnea? Well, here is one study, medical record review for a 9-year period. This is Kimball and Carlton. The frequency of apnea averaged during 5 days before and 5 days after cisapride or metoclopramide was looked at in 132 patients. And neither medication reduced the frequency of apnea. Okay, so those medications that are being used for the gastrointestinal motility, for esophageal function, did not reduce the apnea. Next slide, please. So the treatment for gastroesophageal reflux can be seen as follows. First of all, you have to recognize and eliminate aggravating factors. For example, we use an awful lot of caffeine in neonates. And sometimes the caffeine really is not doing very much good for the prevention of apnea. And sometimes we will keep babies on caffeine for weeks and months and almost forget that we are using caffeine in the babies. So keep in mind, if you think that the baby is having gastroesophageal reflux and if the baby is on caffeine, should we really be using that caffeine in this baby? It might be useful to discontinue and see if the baby still has apnea, because that can exacerbate the reflux. Posture. Still some